This is Dr. Bess Miller, and I'm here with Dr. Donald Francis. Today's date is October 13th, 2016, and we are in Atlanta, Georgia at the Centers for Disease Control and Prevention. I am interviewing Dr. Francis as part of the Oral History Project, The Early Years of AIDS, CDC's Response to a Historic Epidemic. We are here to discuss your experience during the early years of CDC's work on what would become known as AIDS. Dr. Francis, do I have your permission to interview you and to record this interview?
Yes.
Don, you have been a national and global leader in epidemiology, virology, laboratory research, and vaccine research and development throughout your career. For this oral history of AIDS at CDC, we are focusing on the early years, beginning in June 1981, with the publication of the first morbidity and mortality weekly reports on the 5 cases of pneumocystis carinii pneumonia among homosexual men. You served in several critical roles at CDC during these early years, including Assistant Director for Medical Science, Hepatitis, and Viral Enteritis Division based in Phoenix between 1978 and 1983, where you designed and completed the trial of the newly developed hepatitis B vaccine. You then moved to Atlanta to serve as Assistant Director of the Division of Viral Diseases, where you established the CDC AIDS Laboratory. This newly organized laboratory performed much of the early work linking the AIDS virus, which became known as HIV, with clinical AIDS. Let's begin, though, with your background. Would you tell me about where you grew up, your early family life, and then where you went to college?
Sure. I was born and raised in California with a strong family history of medicine, with grandfather a doctor, mother a doctor, father a doctor, and really didn't know what I wanted to be in a place like Marin County, California, where we had all sorts of activities and fun, and I was interested primarily in competitive downhill skiing, and I decided I wanted to be an orthopedic surgeon. That was going to be my career when I was a youngster.
So who or what influenced you then to go to medical school? Was it the skiing? Was it the family?
It was really both, together with my early studies at Berkeley in science. And I'm dyslexic, so I didn't do well in English and reading books. They were always an incredible ordeal for me. So science came easily, and so medicine seemed to be logical. And with a family like that, it seemed to be. But no one pushed me. There was no pressure at all. As a matter of fact, my parents were told early on in I don't know whether it was grammar school or high school, that I was not a good student and I would never succeed. And so they never told me that. And so they just carried on. And it was kind of the California freedom piece that
Tell us more about your parents then. Your mom being a doctor, wasn't that common in the U.S. in those days. And what type of doctor was she?
My mother, I think, was unique in that she was very bright, and I think she was at Stanford at the age of 15 or 16, and graduated from Stanford and then went on to Stanford Medical School. And I think much of her choice of going into radiology was based on a woman in medicine. She could see how tough it was through medical school. And so she said that she could control her life if she were a radiologist. And indeed, for much of my childhood and indeed to adolescence, she did her office work in the morning and came home with x-rays and read them at home. So the mother was always at home. Not that we bothered her very much, but she had her area in the basement all full of all the electronic instruments that she needed. And so she could be mother and doctor at the same time.
What about your dad? What area was he in?
It's fascinating. My father was an internal medicine doc, trained in Southern California, and was planning to be a major internal medicine doc in Hollywood. And then came World War II and the draft, and he was drafted into the Navy, but he was stationed and our family was in Colorado, of all places, for reasons that I don't remember. It was training at other docks, I think. And that's where I started my skiing, actually, when I was about 7 years old. But it was that experience that kept him in administrative positions. And he stayed in the Veterans Administration for his whole career and was the director of the whole Western United States in San Francisco. So he was an administrator, interestingly, who, even though he loved clinical medicine.
So then you went to medical school, and where was that?
I went to Berkeley as an undergraduate, and then talked to some wonderful physicians and said, where should I go to medical school? And they said, what are you interested in? And because of my background in Berkeley, I was working on summers and nights at the radiation lab there. And I became interested in research. And they said, well, if you really were going to go into research, interesting advice was really get a background in clinical medicine. So I said, where's the best place to get trained in clinical medicine? And they said Northwestern in Chicago. You know, and I was raised as a Californian, I just thought the whole world was like California. I said, that's fine, I'll go to Chicago. And they said, well, it's cold in the winter. I said, I'm a skier, so I'm accustomed to dressing. Little did I realize that was 7 days of the week that was freezing, not the 2 days of the weekend. It was a shock, no doubt.
So you went to Berkeley in the 60s. Were you a radical then? Were you a hippie? How much of that world did you become a part of?
At that time, everyone was involved in something, and both at Berkeley and ultimately at Northwestern, civil rights was the issue, especially with African American rights, and so we were in the street in both locations, and physicians and medical students were then came anti-war, and we were in the streets every week. So it was it radical, or medical student stuff wasn't so radical, but we had lots of meetings and lots of discussions of with leftist politics and where it should go and where the political system should go, and certainly where the war effort in Vietnam should go. Now that was personalized because essentially all physicians were being drafted into the military, and I was refusing to go, which ultimately led to my career at CDC.
So were you a conscientious objector, or how did that work out?
The issue of conscientious objector was key at that time, and so I applied for conscientious objector status, and you just send it in, and then when draft comes, they decide whether they want you to be a conscientious objector. And there were a lot of advisors then, and so the advisors said, look, Don, you're a medical graduate. That's considered a conscientious objector, no matter whether you're in the Army, Navy, or working in a clinic. So the advice was that it will not work. You'll be drafted. Essentially, all doctors were drafted and sent off to Vietnam. And so I was planning on moving to Canada and talked to some wonderful physicians in the area of where I should go. And ultimately, about this time, I was doing my pediatrics at LA County Hospital. And the head of pediatrics, Paul Worley, was a former CDC person.
What was his name?
Paul Worley.
Paul Worley.
And he said, why don't you go to CDC for a couple of years? That's military service. I said, well, that's a good idea. And I applied and was accepted. Little did I know that would be a career that keeps on going till this day.
So that's how you first heard about CDC, essentially.
Yes, it was from a former EIS officer, yeah.
So you had an amazing EIS experience, Epidemic Intelligence Service being the 2-year training at CDC. Tell us a little bit about your EIS experience.
Well, it's almost comical. By chance, they said, "Where do you want to go?" I said, "California." He said, "No." So I just chose Oregon as the next state to the north. With no career, I was doing my military service, and there was no career plan in this at all. So I got in my van. At the time we all had vans, camper vans, and I drove to Oregon. And before I even got my house, plague broke out. And off I went in my van to see bubonic plague in the United States of America. And it never stopped.
Where was that? Where was bubonic plague?
It was in Southern Oregon. It's always, it's in the animal population there. And if you're out, as these children were out in a rural cabin that wasn't necessarily cleaned of animals or fleas, ended up getting infected with plague. And luckily, the doctor, the doctor saw this big swollen lymph node called a bubo for plague, and didn't know what it was. The cat had fever and had this swollen lymph node. So he, instead of just putting a needle in it and culturing, he actually cut it out and had it sent to the laboratory for biopsy. And luckily, the laboratory, besides looking at it in the microscope, cultured it and got bubonic plague. And that's when I got called down. They said, here you are, an EIS officer
Right.
in your little office, and the telephone rings. We got a case of plague down here. I said, you have a case of what? And you get in and here I didn't even have I think I was still in a motel. So I got in my car and just drove south, and that it didn't stop. I only stayed in EIS for a year and a half in Oregon but during that year and a half, I was just chasing one thing after another. It was fascinating. And then CDC calls and says there's smallpox in Yugoslavia. So that was kind of the beginning of the end of my EIS assignment. So I came back after being in Yugoslavia for, they said 2 weeks or so. We were thrown in quarantine for 2 weeks. So can I cut that? I was quarantined for Ebola, not for smallpox. So anyway, I went off to the epidemic, and it was such a rewarding experience to have one incredible vision of smallpox in these poor people in southern Yugoslavia, which was down in Kosovo, so I came back, and
So was that the beginning of the smallpox eradication campaign in the early 70s?
it was ongoing at that time.
Yeah.
And indeed, the head of that campaign had come back from his assignment in Nigeria. Was heading up smallpox was Bill Foege. And so I got to know Bill, and on my debriefing in Atlanta, and I said, Bill, if that was wonderful public health experience, and if you're ever going to do something big on smallpox, call me.
What was so wonderful about it? What was so big and exciting about it?
Well, it really was the essence of public health. You had a terrible disease with a mortality of 30%, 40%, that even if they were survived, they were horribly scarred and often blinded. A very, very, very bad disease with a very, very simple vaccination that would prevent it completely. And so here I was out seeing all these patients in these hospitals, and then we had at that time the old jet injector, and we were immunizing whole communities in a second, and the outbreak stopped. So I mean, what a simple thing. With a couple of penny immunization, you prevent all this disease. And so I said, Bill, if you're ever going to do something, I'd like to be part of it, because that was really rewarding.
Was that the immediate strategy? Was there numbers counting, surveillance, like in typical, or was it already sort of imbued that you see the cases and you start a vaccination campaign? And was it Was it mass vaccination or was it so-called ring containment vaccination in Yugoslavia?
Well, it was really mass vaccination at its best or worst, however you want to describe it. But Bill had already come back from his discovery in Nigeria that with smallpox, it was very limited vaccination for the people. You know where the patient is, and they're exposing them during the rash period. So you can really, with a little bit of interviewing, find out exactly who's been exposed and vaccinate him and stop. And that's what Bill did, really out of lack of the system or equipment and everything to do mass vaccination in Nigeria when he was there all by himself. And so that's where Bill did the whole thing of figuring out if you really just do good surveillance and vaccinate just those people who are exposed, you can stop smallpox very quickly. I mean, West Africa, once they started that, ended it. Maybe it wasn't weeks, but it was months. Every country that took it on, remarkable. But Yugoslavia was different because it was really, they had bad vaccine and it messed the whole thing up, and they had people everywhere, and so they had to politically use mass vaccination. And that's where we used the jet injectors to vaccinate the whole country within a few weeks. So it was kind of a different political, not to mention epidemiologic situation.
Well, that must have been pretty heady coming into EIS fairly young in person, and here you're controlling smallpox in a whole country. What happened next after that in your EIS?
So I went back to Oregon after telling Bill, if you're ever going to do something interesting, let me know. And I went back chasing bugs in Oregon, from leptospirosis to, measles and all sorts. It was wonderful. And a very good group of people, good health departments. It was a terrific experience. And then the phone rings again. And Building Crowd says, we're going to take on smallpox in the last countries that it has, and wonder if you're interested. I said, sure. They said, where do you want to go? Wherever, And luckily I had taken a fellowship in India right out of medical school for my last quarter, supposedly, but then I stayed onwards, which screwed up all my rotation. Everyone in medicine goes July to July, but I always went January to January because I stayed in India for an extra 6 months. And then, literally, when I came to CDC, I had to do another 6 months, and rotation, and CDC sent me to out of the country to work in Africa again. So I was experienced. When Bill said he wanted to really take this on in a big way, I said, I'll be part of it. And they said, where do you want to go? I said, I don't care, send me to anywhere. And off I went to what turned out to be, 2 years in India to take on the big one. And it was very exciting.
And what was your role in that? Did you vary roles, or did you end up managing some states, or how did that experience evolve?
Well, the system was well set up. D.A. Henderson, CDC grad, was the head of the smallpox eradication program for WHO. And so he started recruiting people in for the big battles, which was India and Pakistan and elsewhere, with the residual cases of smallpox. And
what was he like, D.A. Henderson? He's sort of one of those larger-than-life leaders. What was he like from your point of view?
D.A. was remarkable, and as everyone knows, his obituary was just the last few weeks, so it's sad that he is now gone. But he was about as different from Bill Foege as you ever can imagine. Bill Foege was always, straight and calm and very organized, and D.A. was really a very different personality. And the Foege, and in some ways I'm kind of halfway between, we learned how to work in WHO. And I would never have predicted, Dave Sencer obviously thought DA could survive in WHO, and he did. And he made the smallpox program in WHO, sometimes by steamroller versus politics. But he learned very well, even though he was very boisterous and tough and sometimes not so political. For example, my first assignment was actually in Sudan, and I was having some real political problems. The smallpox was really all but ended, and just trying to get the searches and containment going, and I just couldn't get and the head of smallpox and I were both Sudanese was having problems, and so I needed someone to bring it up the level of the Ministry of Health. And I said, well, I was in contact with Geneva, and I said, maybe DA should come down and, I don't know what I said, but, beat some sense into this. And it was not, the Sudanese are very proper and very nice and kind, and in meetings are, they will say things that you've got to understand what's harsh and what's forceful. And DA comes in like a football player. And I had more problems cleaning up after that than I did before when he came. So yeah, that's the last time I invited him down. But he was critical to have that force in WHO, which can be very, very soft and silent, and an awful lot of people at WHO like their job and don't want to eradicate the disease. I mean, look, when you eradicate the disease, you eradicate your job. So DA was different and was critical to eradicate smallpox. But boy, he was, you had to be cautious bringing him. You wanted to brief him well before he came into a meeting and make sure he didn't chop people's heads off.
Now, did you do the Ebola investigation when you were an EIS officer, or did that come later in your career?
Oh, later was the first outbreak of Ebola, and I was, where was I? In some CDC assignment elsewhere,
Okay.
but it was in the Sudan. And so they called me and said, we got a problem in Sudan. Would you be willing to go help? I said, sure, what is it? He said, well, it's this virus it's really a hemorrhagic disease virus. I said, that's the level of containment and laboratory work that I've never been exposed to. He said, oh, we'll bring you into Atlanta and then you go off. So I went in with 2 days with Joe McCormick in the lab, and then we sent off to deal with Ebola, the first outbreak of Ebola in Africa. And it was dicey. It was very dangerous.
How so? I think we've learned a lot more about Ebola than we ever hoped to in the last few years, but you were there at an early stage.
Well, it's classic CDC. This was Ebola, and we had to find out the who, what, where, and why.
Why you?
Why
Because
me?
you knew Sudan from...
I guess because I knew Sudan, and they said that I worked with dangerous bugs. I said, yeah, plague and other things, but I had never worked with that class of viruses, and not to mention the dangers. I mean, I think about doing a postmortem on the ground outside the hospital in Sudan to get specimens, because we didn't have the specimens. We needed all of that. So here I am with all my respirator and gloves and gowns and such, and outside back of the hospital, because these hospitals were built as temporary isolation units. They were adobe with grass roofs. There was no place to do postmortems.
Were you afraid? It sounds like you at a fairly early age accumulated a lot of pretty heroic experiences. Were you frightened or excited or all of the above? Or?
Well, I think CDC trains you, one, to be excited with something new. But when you start seeing half the doctors who took care of these patients are dead when you arrive, then you realize this is a very dangerous bug. And then CDC teaches you not to get whatever respiratory bugs or blood-borne bugs or whatever. And so here you are out on the ground in Sudan doing a post-mortem with your full respirator and gowns and gloves and all isolation equipment. But you're dealing, by that time, you know that sharp instruments between patients that will move blood from one person to the next are what cause. And here you are with your literally blood all over. You're taking pieces of liver and kidneys and lymph nodes from a patient. You're very careful about what you're doing with these instruments. When you reach, and here I'm sweating in the heat, and it literally starts raining when I'm out there. And now I'm starting to see my skin come through my gown as it gets wet, and I've got blood right there. So you have to be in the middle of this thing, much like we get trained in medicine. You have to be very calm and cool and collected, even when, the bad stuff starts rolling towards you. And so, but that is a risk that most people would say, let's stop, and the guy's dead. You can do it later after the rain stops. But, getting things like that just organized in a place like South Sudan is not easy. So I just moved on ahead and got it done very carefully. And then taking the gowns. Luckily, the very good folks at CDC trained me very well, and that kind of.
Who were some of those? Do you remember who some of the folks? Was it Joe McCormick or?
Well, Joe was parallel to me. It was the people who preceded Joe. It was a husband and wife team, interestingly, that briefed me, and then, and then you go out on your own, and
that's a CDC style of working, also.
Clearly, a CDC tradition that you have been briefed of a new disease. You don't know what it is, but you've been briefed by the appropriately trained people. CDC would tell you, one, it's unknown, so we need specimens. And get them to us so that we can diagnose this disease and figure out what to do with it in terms of transmission. That was your job as an epidemiologist, to take the laboratory and the epidemiologic settings and then join those two together to figure out with a new bug what it is. And it's very well worked out, even though it's an unknown bug. When you're out there, you know what you're doing. But you don't know the real transmission yet until you do the epidemiology, but you do know that an awful lot of people who have been taking care of patients are dead. So nurses and doctors, half of them are dead by the time I arrived, and have essentially left the hospital, so the patients often were at home dying. So that's a that's a situation where I guess you have to be ready for, because I was not the first person who was sent on this. There was a CDC person sent on this before and turned around in Geneva and came back home. Probably a wise person. When I got the call, they said, don't turn around if you're going to go. I said, okay, I'll go.
So after EIS, you went on to do an infectious diseases fellowship and then began and completed a doctorate in virology at Harvard School of Public Health under Max Essex. And before we get into that, what prompted you to do that?
The question is, what prompted me to go to Boston for my subsequent training and to say that I wanted to go to Harvard School of Public Health? You
were a California boy. What happened?
My Oregon girlfriend was at Harvard. That's what happened. And so I asked to go to Boston to get my training and also be with her, and then broke up with a girlfriend quite quickly afterwards, interestingly. And here I am on my own in Boston. It was very interesting process that I came back from one of my home meetings to come back to CDC from India, and asked to send me up to Boston to at least talk to the School of Public Health there. And they were very kind and had me rotate around the various departments and asked what was going on. And the CDC agreed to send me there. What would I be doing? And I interviewed with a guy named Max Essex, who was in the Department of Microbiology at Harvard. And he had this fascinating disease of cats. He was a vet, actually, PhD vet.
Max Essex is a PhD vet?
Yeah. And he was looking at a disease called feline leukemia and was doing all the laboratory stuff and had these houses, fascinating people who had, like cats, and had lots of cats, and especially two in the Boston area, that he was following. And these people, he provided them with freezers, so when the cats died, he threw it in the freezer, and then he would do the post-mortem from that. And he really thought that someone like me would be interested in combining virology with epidemiology and figure out the transmission of this disease and the natural history. So it was a wonderful opportunity.
So you had done infectious diseases, you had done CDC, you could have come back and made CDC your home career, you could have gone back to the West Coast, which you love, and been an ID doc and epidemiologist. But you instead went, was that a real change in trajectory, or was that just a spur of the moment, this seems neat, or it's an unusual direction?
Yeah, it was an unusual direction. And was it a spur of the moment? I mean, I went there for a girlfriend, so that's, first, it wasn't necessarily a career plan. And CDC sent me there for 2 years to do my ID fellowship.
Mm-hmm. And then did you get them to pay for the virology doctorate?
Yeah, see, that's where comes in, because they called me in my second year, and I'm doing all my lab work. Really, Harvard was very good that you could do your ID fellowship and your lab work. They expected you to really understand something in the laboratory. And then Max said, with just another year, you could get a doctorate here too, instead of just an ID fellowship. So I was taking the classes for a doctoral degree, which were very good too, to really get you solid into microbiology and the understanding of virology. And but then Ebola came and, quote, sacrificed my second year of my CDC-sponsored fellowship training. And I said, well, you did pull me out, and I was thrown in quarantine even for 2 weeks, not to mention the whole month and a half I was gone in the field. So could you, give me another year so I can finish my what you sent me here for? And they were, CDC can be very good about things like that. And they said, sure.
Excellent. Wow, that's...
So that allowed me to complete all of my laboratory research for a doctorate. And then they also were nice enough afterwards to really bring me to Atlanta and let me do most of my writing for my thesis and get all the research published and written. And so CDC was very good, and that ultimately allowed me to get my doctorate.
So why was that interesting? Cats and cat viruses. Was Max Essex exciting and charismatic, and was he the draw, or did you like cats, or how did that work?
Well, I went into cat leukemia not for the like of cats. I'll tell you, bleeding a cat in these houses is not a fun. Here I was trained as a pediatrician, so I knew how to get blood out of funny places and small critters. But your key person in the cat bleeding business is the person who's holding it, because you go down for the jugular veins on a cat, which is right the business end of a cat, and if the person who's holding this cat slips, it comes at you with not a positive feeling towards the person who's sticking the needle in their external jugulars. But that aside, we ended up with a very good team and could really do the epidemiology of this disease. And so my combination, my epidemiologic interest, and Max's combination of his virologic interest and the people in the lab with different experiences, turned out to be a remarkable team. Mm-hmm. And here we had a disease transmissible by close contact in cats that produced immunosuppression and cancer. And when I finished, there was no such disease in humans. The closest was the hepatitis viruses in terms of their transmission pattern and what they did. Because there you're talking about, again, a long incubation period for the hepatitis, relatively long, and then years for primary hepatocellular carcinoma in hepatitis B virus infected people. So it was not a bad match, to be honest. But
so, is that where you got involved in retroviruses? Was a retrovirus? Was that something unusual to be working on in virology? Why all of a sudden retroviruses became of interest? Were there new methodologies to study them? How did that come about?
The interest in retrovirology was really animal-oriented because the cancers of animals and really became laboratory animals where you could get cancer by injecting these various viruses in mice and chickens and not much higher than that, interestingly. Mm-hmm. And it was relatively dull. It was really looking at the cancer virology. How does the transformation in cell culture happen? And it got these viruses became very, laboratory selected ultimately, very different than what we do at CDC. Mm-hmm. It was, but the cat thing was different. Max was not studying these viruses that had been selected to give cancer in mice and rats and chickens in the laboratory, but this was natural history, a natural virus, and he was looking at and I was looking at the natural history of this virus in a population. So it was a very different situation, and who would predict that we would have a retrovirus causing immunosuppression and cancer in humans not too many years after.
Now, why was he doing that? In the field of retrovirology, why would he want to look at the natural history of a retroviral disease? How did that fit in either with the virology, the virologic interest, or was it the manifestations of cellular immunity interest?
I think Max Essex really recognized that instead of this very laboratory concocted virology that most of the retroviruses were working on in mice and rats and others, that this was a very different situation. And here he was a vet from the outside. Mm-hmm.
What was his work before he worked on feline leukemia virus? What were some of his other?
He was, working in general virology. And the other thing that he was, interestingly, I should point this out, Max developed a remarkable allergy to cats. And so he couldn't work with the cats. And so again, bringing in doctoral students like me were very helpful because we could bleed cats and didn't sneeze afterwards for weeks. But he was a very good virologist and saw this opportunity when he saw these clusters that, he was a vet, and so the local vet would call him and said, I have this household that's got lots of feline leukemia in it. And so he was stimulated really by the fact that it was in front of him. Very clever. And then he found these two houses. These people wouldn't, because everyone with feline leukemia by that time in the vet field would say, you've got to put the cat down because it is transmissible. You don't want to give it to other, so they would mm-hmm. euthanize it. But these owners of these cats would not euthanize anything. And so we had a natural history that was set. And so we would go down and bleed them every, 4 to 6 months, bleed all the cats and look at the natural history. It was a wonderful opportunity, and Max saw it. Max saw that this was an opportunity, and so he really became the virology part, and I was the epidemiology part. Putting it together was wonderful. And then we had there was a vet that helped us out down there, and he would do postmortems on all the cats, so we knew exactly what the cats died of: immunosuppressive diseases and cancer. But then I had to find a job at CDC. There was no such disease, and the closest was hepatitis viruses, which was chronic disease that caused an inflammatory erosion of hepatic function and ultimately would produce cancer of the liver. So here I am working on that, and there was a new vaccine that needed to be tested, so it was not a bad match.
Fascinating. So then you moved to CDC and you were in Phoenix, where the hepatitis. Now, why was the hepatitis division in Phoenix instead of Atlanta?
The hepatitis division of CDC was in Phoenix. Interestingly, historically, because hepatitis A was a major problem in the Native American populations, and Phoenix was, in some ways the medical head, or at least a collection of experts in the Native American populations. And there was an old facility there that had both offices and laboratories that CDC had established for Indian Health Service issues. And then ultimately, when hepatitis became such a major problem, they started working on hepatitis, and then ultimately became the division of hepatitis. And so people literally moved out of Atlanta and collected there. Now, for me, not thinking about a career, but being a Westerner, I said, gee, that's great. And it fits well with my interest in virology. And Jim Maynard, who directed it, heard that there was a guy who had epidemiologic experience and had a doctorate in virology, or almost a doctorate in virology, and he was perfectly happy to let me work for the first, 4 or 5 months getting my thesis done so that I would have the...
What was your thesis, by the way?
It was the natural history and outcome of feline leukemia virus in real-life settings. And by that time, it was, Harvard was wonderful because your thesis, you'd write the introduction, and then and tell you what you did, and and then you'd literally staple all of your reprints in your thesis, and then you'd have a conclusion all together. So they were really meant to be real scientific, even though it's a book, it was not some thesis of theoretical stuff. It was, real. If you had published papers, put them in there and staple them and tell you, and introduce what's going to come, and then where that led you on the next thing. So it was a very interesting story, actually. I was very fortunate to stumble into Max's lab, and then to have Harvard have that kind of a process that you didn't have to before you just took all of your published papers and then put them into words in a thesis, which was really silly. Harvard was very practical and indeed encouraged it. If you get them published, then let the value of a published paper stand in your thesis. And so it was relatively easy to put it all together ultimately.
So now, what did you work on when you got to Phoenix? You were there for about 5 years. What were your areas?
Well, the big thing at the time was a vaccine that looked like it may work to prevent hepatitis B. And the question was how to do a phase 3 study of that, and how would you design it so that you could have at-risk people that were, the more at risk, the fewer you'd have to do in your phase 3 design.
So the phase 3 being?
The actual efficacy of the vaccine in a real-life setting, where you take a group at risk of the disease, in this case hepatitis B, and some of them get vaccine and some of them get placebo on informed consent. They all come into the study I had not done a phase 3 trial of a vaccine before, and this was a major challenge. But interestingly, the group at CDC in Phoenix had been doing an epidemiologic study of hepatitis B in gay men in 5 cities. And so the suggestion really made by Jim Maynard was, can't we do a phase 3 trial of the vaccine there? And so I then met with Merck and see what would they provide vaccine and indeed placebo. And then I went out to these 5 sites and saw if they were interested, and they were.
So it was all gay men?
It was all gay men. And that the challenge, in a way, for a vaccine, you want gay men who had not had hepatitis B yet.
Mm-hmm.
I mean, if they're already infected, what's the vaccine going to do? And so when we knew that, gosh, well above half the gay men who came into these studies were already infected with hepatitis B. So we had to, ultimately bring all of these folks to our headquarters and talk about how to do the study, and then design the protocol, get the approval of the various committees at both ends, get the money to do it, and the budget that it would take. And luckily, we were fortunate that we could put all that together and do a study of the efficacy of hepatitis B vaccine in a natural setting. And it turned out to be a remarkable vaccine. This was the old plasma-derived vaccine taken off of carriers of hepatitis B virus, human carriers, and then inactivated. Ultimately, it led to, when recombinant technology came in, you could do the same thing, make the surface protein of the virus by recombinant technology, and we had to do follow-up studies of that. But this one was the old plasma-derived vaccine, and turned out to be very effective in preventing hepatitis B. And then we expanded that, looking at some studies outside the United States, and collaborated with various groups to see the efficacy in the real challenge of hepatitis B was preventing mother-to-infant transmission, because if the mother is a carrier of hepatitis B, the infant had a very high probability of being infected. And that is the kid that ends up with cancer of the liver 20, 30 years later. So that was a critical study to do, and we ultimately found folks in less developed countries who were interested in doing these studies, and did the phase 3 study of perinatal infection by vaccinating the baby. As soon as his little butt would come out, we'd vaccinate the baby. And remarkable success there in preventing infection and ultimately cancer of the liver.
Even if the mother was hepatitis B positive, you could get the baby and prevent hepatitis.
We knew at the time that these babies were not infected when they are born.
Okay.
They are exposed when they are born. It's not transplacental.
Okay.
And so soon after they were born, they would become infected in much higher than the 10% of adults that get infected would ultimately become carriers. And then 20, 30 years later, these are the kids with chronic hepatitis and hepatoma. So it was absolutely, if you couldn't prevent that around the world, including the United States, but certainly in the developing world, the vaccine wouldn't have much effect, to be honest. But this set the stage for newborn immunization of hepatitis B and the elimination of it.
So were a lot of the studies then done in Asia, or? Yeah.
Then we carried on. Then it became the issue of is it practical to immunize all kids? And so we collaborated a lot in People's Republic of China and Thailand of how to immunize kids in the newborn period, and then that became the standard of practice and essentially eliminated the terrible diseases of hepatitis B. Remarkable.
So was CDC doing much international work at that time?
Well, look at my experience. I mean, look at my experience. I ended up working in the United States, let's say for the gay male study, but doing an awful lot of my hepatitis B work outside, advising WHO and ultimately doing the phase 3 studies of perinatal transmission.
So CDC had quite a presence, really,
Oh, yeah.
internationally.
I mean, if you think about my work with
Your own-
CDC, it was CDC had a very close relationship with WHO and then had its own collaboration around the world. So CDC was, some of this is my naivety of how wonderful CDC will be and can be, because we never had lots of money. We had to beg and borrow and push here, but they saw how, I think Washington saw how productive CDC was and would support. And then you get leaders like Bill Foege who were going to, eradicated smallpox, and look what we could do. And so they could really
Think big.
think big. And then the history gets more difficult with HIV because the politics.
Let's
in the
move
way.
on to HIV, AIDS. So while you were still in Phoenix, you became a member of the newly created CDC so-called task force on, it wasn't called AIDS, it was Kaposi sarcoma and opportunistic infections, KSOI, in 1981. So can you tell us about that early experience, those early years where you're in Phoenix, but you're on the task force? What was your role, and what were some of the early hypotheses? How did that come about?
Well, this was a new disease that affected a group that Jim Curran and I had. Jim Curran collaborated with us a lot. He came from sexually transmitted diseases and mine from hepatitis. And with the vaccine studies, it was the STD clinics that were used in the United States. So I knew Jim very well, and so he called me straight away.
And Dr. James Curran was the head of the task force.
Right, he was the head of the task force from sexually transmitted disease, because here you had this disease of gay men that looked like it was sexually transmitted. And Jim had worked with me with my work, and he says, this looks like a transmissible agent that's causing immunosuppression and cancer. And didn't you do something like that in cats? Because he knew me well.
Was it that early that you had those discussions?
Oh, yeah. Oh, there was, you see the pictures of that early task force, and there's not a person in that circle that didn't think this was we were rather biased coming from CDC's infectious disease side, dealing with the disease that causes immunosuppression and cancer. But I remember their early meetings, I would just take the combination of hepatitis B and feline leukemia and said, there's your virus. And I don't think there was a person in the room that didn't think that this was a transmissible agent. After all these people in that room had worked with gay men sexually transmitted diseases forever. So what are the odds of either hepatitis or gonorrhea or syphilis or whatever you want, herpes, viruses, bacteria, they had all of it. Mm-hmm. And so it was not, it sounds, remarkable later, but it was, at the time, it was, everyone had that bias. Now, there was other hypotheses.
What were some of the other hypotheses?
Well, one of the major ones
Controversies.
was, one of the major hypotheses here was that there were drugs that are medications or whatever that these people would take, and some of the gay men, in order to have the sexual activity, they had remarkable sexual activity. And I think all males have limits, and so if they continue to want to have sex, there were these various drugs, inhalers that they were using that were sold with various remarkable names on the street. And so some of the hypotheses that
So those were the poppers?
were the poppers, yeah. And
Nitrate,
amyl nitrate and
isobutyl?
isobutyl.
Yeah.
So there were several drugs that these guys were taking. So that had to be tested in the overall early epidemiologic studies. And Jim Kern and Harold Jaffe et al. Did these epidemiologic studies very early and showed that it didn't look like it was associated, because you take a control group and they were taking the same amount of drugs. So it didn't look like the drugs were a key piece in the evolution of this disease towards the whole KSOI outcome. And so it looked like here you had a bug that clearly from the natural history, these young men had some clinical signs of disease long before the fatal forms, the Kaposi sarcoma and the pneumocystis and all the other immunosuppressive disease came along. And that we knew from the clinical researchers working on it that this was associated with this decline in some of the very specific lymphocyte populations. And so this looked like something that had occurred long before the onset of disease. So now we're back to this acute infection with a late manifestation.
Now, was feline leukemia virus a lymphocytic cytopathic infection?
Very limited cytopathology with feline leukemia virus. It ultimately just caused immunosuppression of specific T cells, but not as dramatic as you saw with AIDS. But it ultimately, these animals died of their infections. But it was, and it was a piece of it, but not as dramatic as we saw with AIDS. That was, I mean, interestingly, it was often the dermatologists like Mark Conant in San Francisco and others in New York who said, I'm looking at these guys, and suddenly they come in with these Kaposi sarcoma lesions, because often they came to the dermatologist first. And then someone pointed out that let's start looking at the immunologic makeup of them. And even though they were, except for these red bumps on their skin, were otherwise healthy, but their immunologic function was not. And then if you followed them, these docs were very clever, both in New York and San Francisco, that continued to follow them and saw this remark. Now we had monoclonal antibodies that could subtype the subsets of cells in the body, and they could literally see the decline. And so the natural history of this was really very, very well worked out even before we got a virus out.
So now the cell counters, the ability to differentiate between CD4 and CD8s, was that a relatively new technology certainly in terms of clinical use, but even research?
Yeah, on the early days of AIDS, it was the laboratories that had these remarkable instruments that poured blood in the top, and it would drop individual cells through a reader hole, and they could tell whether it was a different, B cells, T cells, and ultimately subsets of those by putting monoclonal antibodies on them that would light up and tell me which one it is. And then this is really the combination, again, that we saw with vaccines, is the combination of having technology, in physics come into, in electronics, into instruments that allowed us to make vaccines, allowed us to do subtyping of cells in the body. So in all of our field public health, an awful lot of the stuff we use comes from, intense laboratory work and engineering, and it allows us to just gallop ahead and understand.
Now, where was CDC on this? So, I guess let's move you to CDC now, and Atlanta. I guess that was 82 or 83. You become the assistant director for the Division of Viral Diseases and coordinator of all of the AIDS lab work. What was the status of CDC labs vis-a-vis this type of work? Was it sophisticated? Was it spotty? What did you find when you got here?
Well, here I had come from the hepatitis division, and Jim Maynard, who headed it, was very interested in supporting the laboratory aspects. And so we had some very good PhDs that did hepatitis virology work. And then I started initially commuting from Phoenix to Atlanta, and leaving my family alone in Phoenix while I started working on what do we do with the laboratory at CDC. And I met with Walt Dowdle and Fred Murphy, and they said, I think you should go down and see the laboratory that you have. And Phoenix was, not the Rolls Royce. It was a very good laboratory because Jim Maynard was very aggressive in fighting Atlanta for money, and successful to build a laboratory, which was essential for these modern virologic studies. Hepatitis virus didn't grow well in the laboratory, so you had to figure out laboratory techniques to what they were, to identify them. And so Walt brought me in. And
now, Walt was the Division of Viral Disease
correct.
Director.
Walt Dowdle was, and Fred Murphy was
CID.
CID, right.
Yeah. Center for Infectious Diseases, yeah.
And so they said, why don't you go down and look in the lab? And, it's in the movies of this, in the drama of, but it was just about as bad as has been portrayed in the movies.
The movie, the band
played on, where, the cabinet falls on top of me when I walk in the lab. And it was just about that bad. It was very primitive. Paul Fiorino, the poor guy who came out of EBV type work, was working on this. And we had very good electron microscopy showing these viruses and stuff, but the rest of it was really crude. And so we had to build a new laboratory with no money, and so it was all, patched together. And I wasn't going to tolerate any compromise of safety here, because if we didn't have to work on it, fine. But if we're going to work on it, I don't want any of my laboratory people to get 100% fatal virus. And just because it had a long incubation period, don't kid yourself. This bug is very dangerous, and aerosols, so we had to work in cabinets. We had to treat this as a very dangerous bug.
What was your strategy for strengthening the lab? What's CDC's role? Is it to link epidemiology with clinical specimens? Is it to identify the virus? What were your hopes for the lab as you're trying to put it together?
I think the remarkable thing about CDC is the historical integration of laboratory science and epidemiology, because if you do that, you can discover new bugs and understand the epidemiology far faster than specific research labs at NIH level. I mean, they're very good at getting sequencing and all that, and understanding some of the cellular level, and that's NIH's role, and it's terrific. But CDC's is really ultimately, you want to understand the disease so you can prevent it with whatever tools you have at the time. And so there was a strong tradition of doing this at CDC and having an integration of laboratory. For example, I came out of the hepatitis unit, and that was laboratory and epidemiologists really in the same offices, same building. And so that's the way it was supposed to be. But unfortunately, the closer you get to Washington, D.C., the more difficulty CDC had in getting budget to continue to support all of these activities. And so when I came and saw the laboratory that I was supposed to build in Atlanta, it was just a shock, because compared to what we had out there in the bush in Phoenix, it was nothing. And so it had to be built from the bottom up.
And what did you want to build? To what capability?
Well, to at this time to identify and figure out what this virus was, the basic epidemiological, virological interaction,
Okay.
to understand the transmission and develop tests of the bug so that you can figure out where it's going epidemiologically, and then ultimately to understand enough about it so do you understand the immune response and can you make vaccines and prevention and
Okay.
treatment and the like. It's all, I mean, frankly, CDC's done that for bugs since it came into existence.
For viruses, though?
Well, viruses were, I mean, you're not putting them in cell culture, I mean, onto agar plates like a bacteria and be able to see it. But, you know, even parasites are difficult too. So CDC had this both, you know, virus to bacteria to parasite experience.
But was this going into sort of new territory in some ways from a laboratory point of view to have CDC actually identify a retrovirus? Or you didn't know it was a retrovirus, so yeah.
I mean, was it new for CDC to discover new bugs? No, CDC had a long history of it. But it was confusing from the politicians and the budget standpoint. They said, oh, NIH does that kind of research. But CDC had a long history of being part of this and collaborating with NIH so that we would have the epidemiologic specimens. You need the person who has the disease and a control who doesn't have the disease if you want to check them for whatever bug is in your hypothesis. And so we had a long history of that.
Okay.
Unfortunately, this was a time when the politicians didn't understand what the responsibility of government was in public health. And so it was a very, very different time than my previous experience at CDC.
So did you feel supported by your superiors or some of your superiors? How did you approach the issue of we don't have money, we can't do what we need to be doing?
Well, when you're at CDC, you have a lot of experience in saying we don't have any resources, so how are we going to get it done? Let's all work together to get it done. And you know, the early director of CDC was Bill Foege, and then Walt Dowdle for the Center for Infectious Diseases, and we all knew that we would have to work on these budgets and you know, put them together and fight and then push whatever buttons we could in Washington and the like. But that had been common practice and not the best way to run public health. But there was usually somebody in Washington who understood. CDC's office in Washington knew the ways to work these things, and then we would push them with data and presentations and such. And so this was not an interesting research on an NIH level. This was a disease that was killing lots of people. And we, very soon, even before we had the virus and the serologic test to see where it was, we were doing these large, we and others were collaborating to do these large bleedings of gay men and looking at the immunologic damage. And so you had an idea that there was a huge group of people who were probably destined to move forward in the natural history here. And so that all of our, we'd worked with dangerous bugs around the world, but our eyes were wide open that this was something very, very bad. The interesting part politically was not just the risk groups involved, which was difficult to an extent and got worse with time, but it was the slowness. And just by chance, here we were working with something like hepatitis B, where we could see these little kids who were getting infected in the newborn baby, and they would have cancer of the liver 20, 30 years later. And so for us, we were already in this long incubation period, understanding of long incubation period phenomena associated with acute infections. And it was part of our vocabulary at CDC at the time. We didn't have any trouble, but we had to translate that politically. And here we've been working with gay men for hepatitis and sexually transmitted disease at CDC for decades, but we didn't really understand going to Washington and saying, well, there's gay men and IV drug users with this bad disease. We had to do something about it. And they would just say, oh, we would say, this is our population of our society, and we know that you get sexually transmitted diseases in gay men that goes to other people. It doesn't just sit there, and it's not an island in the middle of a society. It is part of society. But really, by this time, we had these, indeed, a Republican director of CDC soon, and all the Republican, and this is really a Republican-Democratic issue, that the Republicans wanted to stop spending money in the government, and we, with our, and some Republican helpers, but primarily Democrats who understood that the society that takes care of itself will save money and lives in the long run, so let's understand the disease and do something about it. Don't tell me that they're gay men or IV drug users. We know that there are sexual contacts or family contacts of these that'll get the disease and it'll spread. But these guys were just terrible.
So these guys were the Reagan administration.
This was Ronald Reagan and his group of conservative Republicans. I mean, the Hollywood side of Ronald Reagan, there's certainly enough gay men, Rock Hudson and all of this stuff that could talk to them and be friendly with them. But there's a whole group of, I don't know where it would come from, but it comes from this anti-gay thing that made just no sense at all. And maybe it was just convenience of saving money. We don't need to deal with the gay men because it's not a big political, without realizing how many gay men were in their staffs and other elected officials around them. And so, I mean, we all in this game became politicians who started to understand this. And I mean, our history in public health dealt with people, recognizing when some people in a society get an infection, it goes to other people in society. And so we did all we could to understand who are the people at risk for a new disease. And here we had a new disease that was in gay men, IV drug users, but we also knew that it was in sexual contacts of heterosexuals, and it fit with all of our other diseases we dealt with for time. So there was not an issue of a gay disease or a straight disease. We had a really bad disease that, unfortunately for politics, good for the patient, that had a long incubation period between the time of infection to the time of disease. So people lived for years with a slow decline of their immunologic function because of the replication of this virus. So this combination of a long disease, so that we said there's X number of people with this disease, and it looks like they're all going to get with this infection, and they're all going to get disease. But the politicians said, no, you only have this small few thousand cases, so why are you so worried? And then we'd say, well, it goes into all population. No, they're all gay and they're IV drug users. And so the politicians ended up with the ability, with a long incubation period phenomenon of saying, if I'm elected for 2 years or 4 years or 6 years, why do I care about a disease that you guys say it looks like it's 10 plus years? I can say no, and it's a group of people I don't know they exist. I don't want to know. And you guys are just government asking for more money. And right now, you have elected officials who don't want more money, who say, we want to decrease the amount of money in government. And we would say, but only government does this. I mean, if this is government does public health, you're not going to get the private sector to move in on it. But none of this worked at a national level. And so I was asked by CDC to at least push the process, and so made this initial plan and the multi-million-dollar budget that went along with it. And
now this plan was for prevention or for strengthening the laboratory?
This really was for prevention, which required a lot of laboratory strengthening. It was called Operation AIDS Control, and Walt Dowdle and John Bennett asked me to write it, and so I gave it to them and passed it all around. We all agreed on the wording of it, and it went to Washington. And John Bennett called me in his office one day, and John Bennett was not, in general, a emotional person. He was very technical. And when I walked in, something bad had really happened, and he was very angry. And he said, "Don, we just got the news back from Washington about the funding of Operation AIDS Control. And they said, we're not going to fund it." And the quote, as close as I can make it, was, "Look pretty and do as little as you can." And you can imagine John Bennett and Walt Dowdle's reaction to that kind of a thing. He was furious, and everyone was furious. And I then, soon thereafter, said, "Fine, if that's the way the government wants to do this, I can't work here ethically. Because my responsibility is to control this disease, and the politicians will be long gone when 1 million people die of it. And they'll look back at us and say, you guys didn't do your job." And so I literally got on the telephone and called state epidemiologist in California, Jim Chin, and said, "Could you use someone on AIDS?" And he said, "Sure." I went back to Walt and John and said, "Will you guys send me to home to work on AIDS?" And they said yes. And I packed up my family and moved to California.
CDC had a division of communications. I think that's, given 30 plus years, has become much more sophisticated, and communications itself has changed tremendously. Do you think it could have done more? Was there a failure of knowing the language that would be understood in Congress and in the Reagan administration? Or was it way beyond that?
I think CDC was very sophisticated, and the Washington office and people here had been fighting for years, and moderately successfully to get programs, maybe slower and maybe less money than we wanted, but we had been around the world eradicating diseases and such, and so it wasn't perfect, but it was tolerable.
This was different.
And this was different. This was a very, very bad virus that was invading our population, not to mention we had data from around the world. We went back to our freezers and found HIV all around the world from our studies and specimens. And we were a group of people who had worked with very, very dangerous viruses around the world. And this one really got our attention and our concern. The long incubation period, the ability to transmit sexually and by sharing of blood, and we saw evidence of it everywhere. And WHO and our collaborators said, "Look, we can see this too," and everyone was very concerned. And then to have the Republicans in Washington say, "Look pretty and do as little as you can," was unbelievable to us. Although we could kind of tell there wasn't great support for these kinds of things. When we brought the data to them, you'd think that they would be wise enough to open their eyes and say, for the health of this country and our responsibility as government, we have to do it. And they said no. I mean, it was like talking to a bunch of doofuses whose political beliefs and biases led them astray of their responsibility as elected and appointed officials. And unfortunately, that influence came to the director of CDC and who became assistant director, who came from a background who was not perfectly suited to deal with this new epidemic in gay men and IV drug users and their sexual contacts. And so it was the combination of the politics, the long incubation period, and the people who were the primary source of infection in the United States pointed out that it was heterosexual around the world. This was a huge, huge problem. And these guys were such political, twisted individuals that couldn't understand their responsibility as public health officials, including ultimately by that time the director of the CDC, who became assistant, in the Department of Health and Human Services, that had these bias against whatever. But the pro thing was we want to cut the budget. The bad thing was you need budget to deal with a huge epidemic, so fix it. And that's what we did in the past. They had just found every excuse not to. And that's, when I asked to be transferred to California. And then I became a spokesman in the political realm of California, raising money in the Senate and the Assembly of California. I'm a trained virologist and epidemiologist, and I'm testifying in front of politicians successfully, but this meant that a response was another few years later, and another thousands and millions of people become infected. So it was, here I was, you couldn't have asked for a background and a training of a person to be well suited to deal with a disease like this.
Terribly frustrating.
And it was horribly frustrating and incredibly dangerous, and millions of people died around the world because of it. The world looks to the United States in many ways, the CDC, to set at least some parameters of responding to new epidemics. And here they were told to look pretty and do as little as you can.
So, moving in that direction before you left, in July of 1982, 3 cases of this syndrome were reported in patients with hemophilia A. And then in December of 82, the MMWR published the report on the first quote-unquote possible transfusion-associated AIDS case, which was from California. So this was a 20-month-old infant who developed AIDS following multiple transfusions, including from the blood of a male who had developed AIDS. Can you tell us a little bit about that? What effect did this have among the major stakeholders in thinking about bloodborne transmission of AIDS? So you and your colleagues had already, I think, concluded that, but here was right in your face. What were the initial reactions?
Well, the initial reactions to transfusion-associated at CDC were very different than, again, outside. Bruce Evett here had been working with hemophiliac community for the early years of AIDS. Then the transfusions came as expected, to be honest. If you're talking about this is a disease like hepatitis B that has a long incubation period, but is transmitted by sex and blood sharing. These all were expected to come in, and indeed our feelers were out very early on to let the state and local health departments know to keep their eye out for these things. And so when they came, it fit the picture, and we were ready to blast away at ways to prevent it, and really had worked out many of these even before we had the test for the virus, but looking at least CD4 counts, the likely of people who are donating blood, and just ask them about their sexual activity. And so again, CDC was all prepared. We had meetings, these incredible meetings that have been well described in the lay press and stories in the history of AIDS. And
let's talk about one of those. The first one was in January of 1983. So at CDC's request, the Assistant Secretary for Health, Ed Brandt, convened an advisory committee to address questions regarding transmission of AIDS through blood and blood products. And that included the blood banks, the Red Cross, Hemophilia Foundation, affected patients, NIH, FDA. So my first question is, why wasn't FDA in charge of this meeting? FDA, it's blood banks and blood transfusions is under their purview. What happened with that right from the get-go?
Well, how CDC and the FDA decided who would sponsor this meeting, this was early in the game of AIDS, and so it seemed perfectly appropriate to have CDC do this, but it was not without the collaboration with FDA. There was a major person in the FDA who was involved in this all along.
Do you remember who that was?
Yeah. But this person happened to be gay. And he was very, very good at blood banking and knew it well. But I think there was some maybe personal discomfort, and he was very collaborative. There was not a fight at all here. And I work with him a lot. He was a very good guy. And so there was not the fact that CDC was doing it. We had most of the data of the disease, so it was fine. And FDA was here, but the outcome, it goes back. There's something about this disease and the long incubation period that allows people to deny it. And so the outcome of this first meeting was so extraordinary that my quiet self around the table literally pounded the table. And
did you really pound? I've read that in so many. I didn't know whether that's apocryphal or.
No, I think I pounded.
I've thought of you often when President Obama talks about gun violence. I think, gee, we need Don Francis to pound. And what did you say when you pounded?
I just said, this is so straightforward. You can't walk out of this room saying we need more research, that we need more studies of this. We have the issue of gay men donating blood that's causing death. And it's straightforward. And there was some objection in the gay community, but I had worked a lot with the gay community, and that objection you expected. Why are we being prejudiced? And I literally said that there's not a right to donate blood. This is not a constitutional right, and that we screen out people who have hepatitis B and all these other things. And so for you to receive blood or your family to receive blood, you want it to be safe as possible. And so that argument was just nonsensical. But the blood banks were the evil people. And it didn't really make any sense.
Well, where were they coming from? What was there? Well, we know that there were a lot of concerns that it would dry up the supply of blood, and
there was some truth to that. Because gay men were very good donors of blood. But the publicity that these meetings had, with just a minimal amount of coordination, you could get every female donor from Nebraska to donate blood for the rest of the country. It was just a silly thing. CDC and the FDA and blood banks called for donors. They would come in by the droves because we have this disease and we have to be very overly cautious. And I'm sorry we can't use these donors today, but maybe tomorrow we can when we understand it better. It was not an issue. And these blood banks was, from the public health standpoint, I mean, here we have these biases, and you just assume. I've been working with blood transfusions and hepatitis B for years, and work with blood banks. And
were you surprised by this?
Yes, shocked. Why would you even consider this? What was the rationale? And I think it was inconvenience. Oh, I'm sorry.
Now, what could CDC have done differently? I mean, we always look at what is it about communicating health risks that it's often difficult? It's often difficult.
If we had all the budget in the world and staff to do all of these things, then you could have your public relations and marketing team be advising us doctors instead of being so, go get 'em thing. Could say, well, let's do this politically so we understand and get all the backing of that. If we had those kind of resources, we probably would have done better, no doubt. But we didn't have any resources. I mean, look at every one of us was stolen from some other part of CDC. We didn't even have any money for AIDS specifically anyway. We didn't have time for this. We were doing all the research and putting all this data together and trying to get support out there to understand the disease and to treat it and to whatever was necessary. There are dozens of things for a new outbreak. And CDC should have had millions and millions of dollars put on it right then, and then we could have a whole group working on the transfusion side, which was 1-2% of all AIDS cases. But again, this was a management issue at government level, where they essentially said, CDC, you're not going to have resources to do that, and that we don't. I don't know what their logic was. You don't need public health. We don't need government. What they were saying. I mean, gee whiz, it was. I had never seen this in all the countries I worked in around the world, and here in my own country, with a very, very bad epidemic, these doofusers said, we don't need your efforts and you don't need any money to do what you think is necessary.
Now, had there been agreement to have some type of screening, what were some of the thinking on, was hepatitis B core antibody, CD4 counts? What were some of the proposed screening methods?
The proposed methods for blood transfusion were really quite straightforward. Indeed, there were blood banks in these meetings that reported that they were doing CD4 counts. Now, that's a fairly elaborate laboratory technique, but it was perfectly reasonable to do. The other thing that we had data from the AIDS cases that 70-80% of them were infected with hepatitis B virus because of the same transmission sexually. And so we were recommending screen out the blood for hepatitis B virus infection, which you do anyway for the virus itself, but why not just use the antibody, which would get the other 70-80%, and would get you, would be, one, it would decrease, at that time we called it non-A, non-B hepatitis, but would reduce 30-40% of non-A, non-B, and you'd get rid of 80% of HIV. So we thought that was very straightforward, and we presented all the data at the blood bank meetings. God. And these blood bankers would say, what? Why would we do more tests and then have to go find more donors? It just was,
Must have been very, very disillusioning at the end of that meeting.
I don't think there's very many meetings where I pounded tables with my fist. And it wasn't a frustration with our limited resources and all the difficulties we had with the early days of AIDS at CDC. It was, this is your responsibility. This is not our area. Your blood bankers are, it was not the difference between FDA and CDC. We spoke the same language. It was straightforward. We could use we knew that these people with AIDS had a very high prevalence of hepatitis B infection, and that we had all these studies that Bruce Evett and others had done finding the donors to these cases, and we could screen out just using antibody to hepatitis B. I forgot what it was 80% effective in screening out, which would not be bad. And then the thought was we could do the T4, T8 ratios too, but that's an expensive machine that blood banks are not going to have. Hepatitis antigen was being done, so to add antibody was nothing. It would cost a couple of dollars a unit extra.
So before they even identified the virus, by March of '83, CDC, FDA, and NIH agreed on some guidelines in the MMWR that members of groups at increased risk should avoid donating blood and others. And then in December of '83, the Blood Products Advisory Committee of FDA met to discuss options of surrogate marker testing. So was that effective? the sort of voluntarily telling people not to donate blood, what were your thoughts on that, and how did the gay community respond to that?
There were, at least in one meeting, there were some very, one PhD gay man who had been involved in science and understood that, but he was very politically active from California, and he gave some objections in a meeting, and I knew him well, and I just said, "Come on, don't have the gay community be blamed for this through transfusions." And they said, "We understand, so just do it, And as a matter of fact, very soon thereafter, the gay community came forth and said, "Do not donate blood." And the blood banks finally came around, but it was not instant. It took time.
So with all these years past, and you look back at it, first of all, how many lives were lost on the basis of that, as far as one can estimate?
Of just the blood
thousands, tens of thousands?
Well, if you think about prevention from behavioral side, the prevention from blood transfusion, around the world, it's millions. And certainly in this country, it's tens of thousands. This is a, relatively difficult bug to get with things like condoms and some sexual caution, blood transfusion screening, clean needles and syringes, all the things that we ultimately did in places like California. But that kind of thing takes months to do. And CDC could have come out with it straight away, and then they let the states work it out there, and you don't have to go through what I had to do when I left Atlanta and went to Berkeley, was to do all the politics in California myself, taking months to change these things, and then getting budgets. Budgets don't come. CDC could have, the former director of CDC was assistant, and secretary could have gotten a few millions of dollars. I mean, this is nothing, but it's equivalent to a war, and the Defense Department has this kind of thing and rallies forth. We should have been able to do it too. But these people literally stood in the way.
There were a lot of trials around these transfusion-associated AIDS cases. Did you testify at any of these, and what was the outcome of those trials?
Well, they asked me to testify, and then it just became, it was endless. And so what I did was I told all of the legal folks who were taking these blood banks on to come into one room with cameras and tape recorders and ask me any questions they wanted, because I was going to do the end. I didn't have time. I just did not. I didn't think it was an appropriate use of my time to be testifying in all these cases, even though I thought my opinion would be important in pointing to where the liability was. And so I did that once, and I don't know, there were a dozen or 20 attorneys, and they all had these cameras, and we recorded the whole thing, and then they used that testimony for their trial.
Did a lot of those people win their
I think eventually, yeah. Well, ultimately there was a fund set up. I mean, this was terrible. These people were killed for no reason, especially later on, who, after we said they needed to be screened. And it was, some horrible cases that were totally preventable.
Before we move towards closure, you were closely working with Max Essex, and in late '83, early '84, there were several groups coming close to identifying the virus. And that was Bob Gallo at NIH, and the French, Luc Montagnier's lab, and Claude Sherman, and Francois Barret. And you worked with them providing specimens from CDC. Can you tell us a little bit about the controversies there and the role that CDC played in providing specimens and in other efforts to identify the virus?
Well, clearly, it's CDC's role, not to mention their history, when you have a suspect new infection, to bring both the lab at CDC and the collaborators outside together to as fast as possible to find the bug. And we were quite limited in Atlanta because of budget in what we could do, but we also had a very good idea where this bug resided and what could be done, and with our experience in retroviruses, ways to identify them. But we needed really good virologic labs to do that. And then, of course, there was the group at NIH, but there was a challenge there with the director of that group, Bob Gallo, who was not a collaborator in a way and a very hard guy to work with. But I knew the French from my past, and
How was that? How did you know the French?
I don't know how I had worked with the Institut Pasteur on things before.
Okay.
And so I think Françoise Barret called me on the telephone, and we talked, and she wanted specimens, and we were more than happy to give her specimens. And CDC, I don't know whether I was going to Europe for WHO meeting or something, but CDC had the money, at least interestingly, to send me to Europe, and I carried specimens and stuff to Paris and spent a couple of days with them. And they, very rapidly, they had the virus, and they got it themselves. They sent it to us at CDC, and they also kindly sent it to Bob Gallo's lab and to other labs. And then the sad thing that came out of Bob Gallo's lab when he announced that he had the cause of AIDS, really before the French had had all the data that we provided them showing that they had the cause of AIDS. Ultimately, his virus was sequenced, and it ended up to be the French virus that they sent him in the post, that he had thrown into his cultures, expecting that it would be mixed with other virus, but this was already lab adapted, and so it just took off like crazy and outgrew all the other ones he was trying to hide by mixing it. And so, but that took years to settle, and was a very, very unfortunate chapter, and unfortunately took the National Institutes of Health, ultimately the director, who was a good guy, to move Bob Gallo out because he did not follow common scientific rules of the trade, and he went on to do his thing elsewhere. But it was a very sad thing for the U.S. government, and CDC is obviously part of the U.S. government, and to have that conflict, especially when the government decided to put Bob Gallo on the stage as the discoverer of the AIDS virus. And we told them, we saw that coming, and we talked to the Assistant Secretary's office and said, this is a very poor idea, because we've got information that, clearly the French, we've been working with the French, and we had that virus growing in our lab. We had all the serologic, we had all our hepatitis B studies. They were grinding it out 24 hours a day. And the silly politicians in Washington wanted to, because they were getting so much criticism for the lack of federal response to AIDS, that they wanted to declare that they found the cause and would make a vaccine tomorrow, So it was just another chapter, and here we were at CDC with all the information, limited amount of resources, fighting all this stuff, only to have our colleagues in Washington make it more difficult.
So now that we've got about 30, 35 years behind us, what are some of your thoughts about that time? Are there things we could have done differently? Was it just bad luck? So much has happened. So many millions of people have been infected since then.
Well, it's some of it is bad luck that this bug, I hate to say it's clever, but it's certainly a great nuisance, well-designed nuisance for our society. Long incubation period, especially. I mean, these long incubation period phenomena. Look at our response just to pollution in the United States. It takes, it only takes seconds to dump it out, but it takes years for the diseases to occur and the impact of plant and animal species. We have a very hard time in our system to respond to slow-moving phenomena. And so we need to talk about that, but we need to get a system where CDC has an alarm ability to say, this is a long incubation period, be careful, because we get suckered in by these bugs. But anyway, so this is a slow-moving, the at-risk populations, I think, were trivial to us at CDC because we knew the rest of the world, it's heterosexually transmitted, homosexually transmitted, IV drug, whatever, dirty needles. That doesn't bother us at CDC, and the leaders in Washington should listen to people at CDC because they know about these things, and damn it, CDC should be able to come up with recommendations that need to be followed. But the current structure of government and CDC's location in that structure of government makes it impossible for CDC to operate on these kind of things. And there needs to be a way that CDC has the equivalent of a National Board of Health or a representative system where they can speak the truth and what CDC needs to combat these diseases without having somebody like these conservative Republicans up there saying no. We do that for our banking system. It's interesting we do not do it for our public health system. There has to be a...
How so for the banking system, the Federal Reserve?
You have the Fed advisory group that says this is what interest rates should be, and some people make a lot of money on that. I mean, it should go down. Some people can lose money on that. There's a lot of pressure in terms of financial loss, and yet the financial community has said that we need an independent group to do that so that we don't have some political forces that do it. We need exactly the same thing in public health. You can't have CDC be tied to these. I mean, often they have very, very good people, but when you see directors of CDC who are very, very good people leaving because of the political influence, then you know your new director's not going to be quite so independent of the whatever party is in charge. The director of CDC should speak for the health of the people, and the politicians be damned. And they've got to follow what CDC says because they're experts. And so do we need a larger board or advisors or something to insulate it? It is not going to work the way it is, I can tell you. And I have written this in the literature and have gotten lots of support, but so far we do not have the political force in the elected officials or the president to say, we cannot do this anymore because people die because of it. Very simple. And some of that is the fact that people are dying of these long incubation period things, and they're out of office. And so it was not on my watch. And so especially these long incubation period phenomena, you do need a wise group of people to help, and the acute ones too, but to support CDC's expertise and translate that into political activity of the positive nature and not this negative stuff.
How did your early work on AIDS affect you personally?
In several ways. I mean, the worst thing for me with AIDS was I knew these people.
The people that were dying.
Right. I didn't have that experience from Ebola or whatever else. These were, acute diseases, and I hadn't met them before. I stopped going to funerals in California because I knew so many people, really good friends of mine, who were really wonderful people in the AIDS community that did great things, that were dying. And I couldn't deal with it. There was so much death, and here they're now, my colleagues and friends are dying. I just stopped going to funerals because I had to keep functioning. So it was like no other. I'm here. I worked around the world on all these bad diseases, but nothing like this where you're dealing with it personally, with lots of really good people that died of this disease. So that was a big factor, interestingly, and then the frustration of, even going to Genentech and starting work on an AIDS vaccine, it was frustrating because it was difficult scientifically and frustrating. But that was part of the battle. That I could accept, but the lack of resources to make a vaccine, I couldn't accept. It's been very difficult to get resources to work. For an easy vaccine, it would have been fine, but for a difficult one of a virus that changes so much, this is not straightforward. But the effort, to me, has been really left only partially done because of lack of resources.
So you stayed working on AIDS for all of your career?
No. My staff at Global Solutions for Infectious Diseases works on the AIDS vaccine stuff. And I do dengue and other things outside the country. I don't work in the United States anymore. I have so many years to contribute, limited now, and I'm going to work on things I can get done. And if the United States wants to trip and stumble on itself, so be it. I got a lot of other countries that could use our help. So things like a dengue vaccine will be out. Now there's some NIH people that did that, and we're testing it now in Brazil, and you watch, we'll get a dengue vaccine before there'll be an AIDS vaccine.
Yeah. Any other concluding thoughts?
The concluding thought for me, for the United States of America, is to look at the AIDS model and find a system that organizations like CDC can operate in that'll prevent deadly diseases coming into the United States, and have it be free of the political influence of these elected officials that have no idea of the consequences of their inaction.
Thank you.
My pleasure.